Hello everyone, welcome to my channel. In this video, we're going to cover the pathophysiology, diagnostic approach, and treatment of mechanical and inflammatory arthritis. Arthritis is a common disorder of the joint. We have mechanical arthritis, known as osteoarthritis, which is the most common, with 80 to 90% of causes falling under this category due to a degeneration of the cartilage. There's also inflammatory arthritis, much less common, 10 to 20% of cases, due to an imbalance in the immune system depending on the underlying cause. Now, to understand the pathophysiology, we first need to look at how a healthy joint functions. The joint is lined by a synovial membrane which secretes synovial fluid. This fluid plays a key role in lubricating and stabilizing the joint, as well as nourishing the cartilage since the cartilage is avascular and doesn't receive direct blood supply. Cartilage itself is essential for smooth movement. It contains special cells called chondrocytes. These chondrocytes are incredibly important. They produce key components like proteoglycans and type 2 collagens, which help maintain and repair the tissue. Chondrocytes also release enzymes like matrix metalloproteinases and uricanases that break down damaged cartilage to keep the joint healthy. This is extremely important to understand the pathophysiology of mechanical arthritis and inflammatory arthritis. Now, onto the pathophysiology, starting with mechanical or osteoarthritis, there are several risk factors to this condition, including age, which lowers the cartilage ability to regenerate, weight, which puts mechanical pressure on the joints, increasing the load, genetics, as some individuals are naturally more susceptible to joint degeneration, and of course, repetitive trauma, typically from physical activity. All these things add up to the mechanical stress on the joint, which causes an overactivation of the chondrocytes, the cells that maintain healthy cartilage. When these cells are overactive, there's an imbalance. The breakdown enzymes, such as matrix metalloproteinases, become more active than the repair components, leading to a thinning of the cartilage as the damaged tissue is being broken down faster than is being replaced. Over time, the quantity of the healthy chondrocytes decreases, lowering cartilage production even more, resulting in the narrowing of the joint space, one of the hallmark characteristics of arthritis. As cartilage is lost, the subchondral bone, the layer of the bone just beneath the cartilage, must take on more stress, and it's because of this we have an increase in the bone density on the x-rays. A condition known as subchondral sclerosis is seen. At the same time, the synovial membrane becomes inflamed, contributing to both joint pain and reduced mobility. In an attempt to stabilize the joint, the body tries to compensate by forming new bone growth known as osteophytes. To remember the key factors, use the word loss. L for low joint space from cartilage thinning, O for osteophytes as compensatory mechanism, S for subchondral sclerosis from the overload of the bone, S for subchondral cysts, which form when the synovial fluid enters bone through cracks in the cartilage. It is this entire process that ultimately leads to the painful stiff joints of the mechanical or of the osteoarthritis. Now, let's talk about inflammatory arthritis, which is a bit more complex since it depends on the underlying cause. It can be due to a direct invasion by the infective organisms, which can lead to septic arthritis, for example, a dysregulation of the immune system, with the body developing autoantibodies, as in autoimmune diseases such as rheumatoid arthritis or lupus, or genetic predisposition, such as HLA-DR4 in rheumatoid arthritis or HLA-B27 in spondyloarthritis. So what happens in inflammatory arthritis? There's huge flow of pro-inflammatory cells into the joint, such as T cells, B cells, neutrophils, and autoantibodies, all attacking the synovium covering the joint. The immune activity is particularly active at night because cortisol, which is a natural anti inflammatory hormone, has a circadian rhythm and decreases at night. Plus, the joint immobility while sleeping contributes to stagnation, which lets inflammatory cells build up. The result swelling, pain, and heat in the joint, leading to the classic symptom of the morning stiffness. In more severe or long lasting cases, this chronic inflammation goes one step further, eroding both cartilage and bone, eventually causing joint destruction. So, to recap, inflammatory arthritis is triggered by an overactive immune response, sometimes set off by infections Autoimmunity or genetics. The hallmark symptom is morning stiffness due to the nighttime immune activation and reduced cortisol. It can lead to permanent joint damage if not properly managed over time. And that's the pathophysiology of inflammatory arthritis. Of course, osteoarthritis is due to a degeneration of the cartilage with an overactivation of the chondrocytes and an imbalance towards the breaking enzymes due to a mechanical stress, which explains why it gets worse with work and it gets better with rest. Diagnostic approach to arthritis. Now, when evaluating an arthritis patient, your initial and most important step is a thorough history and clinical examination. One of the key differentiation points early is trying to determine whether you're dealing with inflammatory or mechanical arthritis. And here's how to know the difference. The morning stiffness in inflammatory arthritis lasts more than 30 minutes, which is extremely typical due to a decreased cortisol levels during the night and the accumulation of inflammatory cells within the joint. In mechanical arthritis, the stiffness is short, typically less than 30 minutes, and improves immediately with activity. The joints are warm, swollen, and tender in inflammatory arthritis, whereas in mechanical arthritis, swelling, if present, is less intense and the joint is not typically warm. For the effects of activity, inflammatory arthritis, the symptoms improve with activity. The motion spreads out the inflammatory mediators, whereas in mechanical arthritis, the pain worsens with activity from wear and tear in the joint and improves with rest. The joint distribution for mechanical arthritis, it most frequently affects the weight-bearing joints such as the knees, hips, and the spine, whereas in inflammatory arthritis, it tends to involve the small joints like in rheumatoid arthritis, typically the wrist, the hand, and the foot. For systemic symptoms in inflammatory arthritis, try to look for fatigue, low-grade fever, weight loss, etc., which is not seen in mechanical arthritis. As for inflammatory markers, elevated ESR and CRP are common in inflammatory arthritis, whereas they're normal in mechanical arthritis. For quick recap, if it's better with rest, think mechanical. If it's better with activity, think of inflammatory arthritis. If a patient is complaining of morning stiffness for more than 30 minutes, swollen, warm, and sensitive joints, increased inflammatory markers, systemic symptoms, you probably have inflammatory arthritis. But if the joint pain worsens with activity, has no systemic symptoms, reveals normal lab markers, and occurs in weight bearing joints, it's more likely in mechanical arthritis, such as osteoarthritis. Alright, so we've covered mechanical arthritis and its characteristics. Now let's look into inflammatory arthritis, which can arise from several causes. The major categories include infectious, metabolic, and systemic autoimmune diseases. In this section, we'll focus on infectious arthritis, a very important and often an underestimated cause of inflammatory joint pain. First, we have septic arthritis, the most common infectious arthritis, typically presenting with monoarthritis, meaning it affects only one joint. Urgent diagnosis and management are critical to prevent a joint destruction. The synovial fluid aspiration is mandatory, presenting a purulent fluid with more than 100,000 white blood cells with neutrophil predominance and positive gram stain and culture. Systemic manifestations include fever, chills, and white blood cells increase. Always look for possible entry sites such as skin infections, ENT or dental infections, urinary tract infections. We might have oligoarthritis in immunocompromised hosts such as patients with diabetes, corticosteroids, cancer, or HIV. There's also infective endocarditis can present with joint pain, fever, and systemic symptoms. Consider in patients with non-valvular heart disease, IV drug use, recent dental or invasive procedures, key findings, new or changing murmur, rod spots, Osler nodes, runway lesions, and splinter hemorrhages. Don't delay in ordering transthoracic or transesophageal echocardiography and use Duke's criteria for the diagnosis. There's also gonococcal arthritis. It's a sexually transmitted disease often seen in young, sexually active individuals. In females, consider whether there is cervicitis, abnormal vaginal discharge, or dyspareunia. In males, consider with arthritis, penile discharge, or dysuria. There's also fever, tenderness of the joints, tenosynovitis, and skin lesions such as pustules or vesicles. Another common infection, brucellosis, should be suspected in patients who had recent contact with infected livestock such as goats, sheep, or pigs, or consumption of unpasteurized milk, presenting often with the classic triad fever, joint pain, and swelling. Diagnosis is made with positive rice agglutination test. You should consider blood cultures and serology. There's also viral arthritis, and the most common viruses are hepatitis B and C, HAV, parvovirus B19, rubella, roseola. It should be considered if the patient has viral symptoms such as rashes or past history or viral infections. So, to recap, infectious arthritis is common and often missed. Always take a thorough history, including travel history, sexual history, exposure to animals, immunosuppression, recent infections or procedures, and don't hesitate to send for joint aspiration, blood cultures, focused serologies or imaging. And the most important thing to know is that early recognition and immediate treatment can prevent serious complications. Now, moving on to metabolic arthritis, another common source of joint pain due to the abnormal deposit of metabolic products in the joint. The two most significant conditions are gout and pseudogout. We're going to focus now on gout, which is due to a deposition of uric acid crystals in the joint, triggered by alcohol, red meat because it's rich in purine, renal failure due to a decrease in the excretion of uric acid, diuretics, especially thiazide diuretics and loop diuretics. It should be suspected if a patient presents with a sudden development of redness, swelling, and intense pain, most often affecting the first metatarsophalangeal joints, meaning the big toe. The investigations for serum uric acid typically elevated. However, it can be normal in up to 40% of patients during acute attacks. In X-ray findings, we have typical rat bite erosions, also known as Martha sign or G sign. We also have pseudogout or calcium pyrophosphate deposition disease due to a deposition of calcium pyrophosphate dehydrate crystals in the joint, common in older patients, typically older than 60 years, often idiopathic, or secondary to hemochromatosis. Well, in hemochromatosis, we have an iron overload which inhibits an inorganic phosphatases, the enzyme that normally breaks down pyrophosphate. The inhibition leads to pyrophosphate accumulation, which combines with calcium, causing calcium pyrophosphate crystals deposit in the joints. Also seen in hyperparathyroidism due to the excess in PTH that causes the imbalance of calcium phosphate metabolism, which leads to hypercalcemia and promotes joint calcification. The most common joints involved are knees and wrists, as opposed to gout, which more typically affects the big toe. And in the X ray, we find chondrocalcinosis. It's a linear calcification in the articular cartilage. The key blood tests to order are in hemochromatosis, measure serum iron, ferritin, and transferrin saturation, all elevated. In hyperparathyroidism, measure PTH and calcium levels, both elevated. And finally, connective tissue diseases, they are less common than other forms of arthritis, more specialized and extremely interesting. Let's try to simplify the mechanism and the most important disorders. Well, for their mechanism, it's due to an immune dysregulation, the generation of autoantibodies with a loss of self tolerance. The immune system basically starts attacking the body's own cells, resulting in systemic manifestations. So, whenever you see symmetric and chronic polyarthritis with systemic features, meaning weight loss, chronic fever, organ involvement like kidneys, lungs, etc., consider connective tissue diseases. Let's start with the most common one, and it's, of course, rheumatoid arthritis. We're not going to spend too much time on this one. If you'd like a full explanation on any of these disorders, comment below and let me know which disorders you'd like me to dissect in an exclusive video. Well, rheumatoid arthritis is an erosive, symmetrical polyarthritis. Laboratory findings typically demonstrate an increase in ESR and CRP, the same with all connective tissue disorders, rheumatoid factor present, and anti-cyclic citrullinated peptide present, which is extremely specific for rheumatoid arthritis. Next, we have another famous disease, lupus or systemic lupus erythematosus. Lupus is also called the great imitator because it can mimic so many other diseases. Features including non-erosive and migratory polyarthritis, meaning it can touch the knee, then go up to the wrist, and then back to the foot, etc. With skin involvement, it has the characteristic a butterfly rash or the malar rash over the cheeks and the nasal bridge, sparing the nasolabial fold, which is extremely important because it allows us to differentiate it with another connective tissue known as dermatomyositis. Well, we also have renal involvement, typically glomerulonephritis, involvement of central nervous system. It can present with seizures or psychosis, or we can have cirrhosis, pleuritis, and so on. Again, it can mimic any disease, so we can have any type of manifestation in lupus. In labs, we have positive ANA, of course, it's extremely important, positive anti-DNA, anti-SM, and we have low complement levels C3 and C4. There is also Sjogren's syndrome, or known as Zika syndrome, typical of dry eyes, dry mouth, often with arthritis. In labs, we have positive ANA with positive anti-SSA and sometimes anti-SSB. On the contrary of lupus, where we have anti-DNA and anti-SM. You need to know that sometimes you find anti-SSA also positive in lupus. There is also systemic sclerosis or scleroderma, not uncommon but easy to diagnose on physical exam. Features it have thickened skin, Raynaud, arthritis, and esophageal dysmotility and the GI involvement, gastrointestinal involvement. In labs, we have positive ANA. This time we have anti-centromer or anti-SCL70 positive. So, what do we need to retain from this? If you have a chronic arthritis with systemic features like fever, weight loss, fatigue, or organ involvement like skin, central nervous system, and kidneys, consider connective tissue diseases. So, to recap, if you have an acute onset monoarthritis with fever, night sweats, recent travel or sex, immunocompromised status, think of infectious arthritis. If you have acute onset, usually the first metatarsophalangeal joint, the great toe, with a history of kidney failure, alcohol use, purine excess, think of gout. Now, if you have acute monoarthritis or acute arthritis of the knees or the wrist, look for history of hemochromatitis, hyperparathyroidism, think of pseudogout. Now, if you have a chronic onset polyarthritis with fatigue, weight loss, organ involvement, consider rheumatoid arthritis, lupus, scleroderma, etc. Key lab test by suspicion. For infectious arthritis, white blood cells count is extremely important, blood and joint fluid and culture. For metabolic, either gout, we have uric acid or serum calcium, PTH, or the iron panel for pseudogout. And for connective tissue disorders, ANA, anti-DNA, SSA, SSB, rheumatoid factors, and anti-CCP with complement levels are extremely important, so don't hesitate in demanding them. Now, for treatment, we're going to start with osteoarthritis. We have non-pharmacological treatment and pharmacological treatment. For the non-pharmacological treatment, it consists of weight loss, exercise, physical therapy, and acupuncture. For pharmacological, we can either have local with topical non-steroid anti-inflammatory drugs or intra-articular injections with hyaluronic acid and corticosteroids, or oral treatment with pain relief medications, or we can have surgery if it's severe or doesn't respond to treatment. Now, for inflammatory arthritis, it's cause dependent, meaning it depends on the cause. If it's due to an infectious arthritis, the treatment, if it's due to bacteria, it's with antibiotics. For metabolic arthritis, if it's gout, we treat the flares with colchicine, corticosteroid, and non-steroid anti-inflammatory drugs. For treatment of prevention, we can either have allopurinol or febuxostat. Now, for CPPD, also we treat flares with non-steroid anti-inflammatory drugs, corticosteroids or colchicine. For connective tissues, we can either have corticosteroids with immunosuppressants or biotherapy. That's everything you need to know on how to approach a patient with arthritis step by step. Thank you so much for watching. If you found this helpful, don't forget to like, subscribe, and hit the bell button so you don't miss the next one.